Okay, good afternoon, everybody. Welcome for joining us. This talk will be by Dr. Dan Rossignol, Treating Spikes and Discharges in Autism. So it's my pleasure to introduce Dr. Dan Rossignol. I'm going to tell you just a little bit about him. Dr. Rossignol is a board-certified family physician and director of Rossignol Medical Center in California, Arizona, and Florida. He serves as a chief medical officer for the Autism Discovery and Treatment Foundation. Dr. Rossignol has published and taught widely on medical comorbidities in autism, including how to recognize and manage seizures. He'll translate the evidence into clear practical steps for families, what to look for, how evaluation works, and how to keep children safe and supported. So there's a lot more information, but I know there's an important talk here. So please help me welcome Dr. Dan Rossignol. Thank you.
Thank you for that nice introduction. So today we're going to talk about seizures and seizure-like activity, which is also called epileptiform discharges in autism. So disclaimers, of course, we're giving some studies here and talking about autism and epilepsy and seizures and so forth, but it's best, of course, to talk to your child's doctor or your doctor about these things before you implement them. So there's an important concept in autism is that and by the way, I'll take questions as I go through, so if you have a question, just put your hand up and I'll answer them as we go along. So there's several different metabolic abnormalities, problems with metabolism, biochemistry, that can cause autism that are potentially reversible. The classic example is cerebral folate deficiency, which we'll talk about in a little bit, and this can actually cause seizures as well in people. So you end up with low folate in the brain, which is a vitamin, a B vitamin, and if it's low in the brain, it's known to cause autism and also epilepsy. So one of the things we're going to also talk about is not only treating, epilepsy and discharges in patients, but also trying to figure out what caused the epilepsy, if we can. And there's not always a cause we can find, but sometimes we can. And obviously, if we can treat the cause, that's better than just medicating, of course. So what we want to do when you see a patient is to screen for these problems. We do a lot of laboratory testing, and we identify biomarkers. Biomarkers are labs or other tests that can identify problems that we can then treat. And so with autism, we're dealing with a psychological disorder, at least that's how it's categorized, but it's got a biological basis, just like a lot of medical disorders. So here's a picture of our brain, and so you've probably seen patients in your life who had a stroke. So if you have a stroke in the speech area of the brain, you might lose speech or not be able to speak. If you have a stroke in the motor cortex, you might not be able to use your arm or leg and be paralyzed. Likewise, if you have a seizure in the speech area of the brain, you might have poor speech or even lose speech. If you get a seizure in the motor cortex, then you might fall down, shake all over. If you get a seizure in the frontal lobe, you might have poor attention. Okay, so the location of the seizure is going to determine what you see, of course, just like a stroke, okay? So we have patients with autism that have seizure activity in the speech area of the brain, and we treat it and they start speaking more. Or they have seizure activity in the frontal lobe, and we treat that and their attention goes up. So the location of the seizure is going to make a difference too. So when we do an EEG or other types of testing, we're also trying to figure out where the seizure is located, and that will help us know maybe what symptoms are related to that. Yep.
So when somebody says or a doctor say that your child has generalized epilepsy,
Yep.
what does that mean? Where is it coming from?
So the question is about generalized epilepsy. What does that mean? That means the abnormality could be through the entire brain, so it's generalized. So this might cause a focal seizure just in this area, or the seizure activity could affect the entire brain. That's generalized. Okay. Or it might just affect one side of the brain, like the left side or the right side. So if you have a generalized epilepsy, generalized discharge of seizures, there still can be an underlying metabolic defect that affects the entire brain. If you have a focal seizure, then you start wondering what's going on in that one area of the brain. Is there like scar tissue? Did the brain not have proper migration? There's wrong tissue there. Did you have a stroke, an injury, brain injury there? And so that's why sometimes with focal seizures, you do an MRI to kind of see if something's going on. Of course, with generalized seizures, you might do an MRI too to see if there's some other cause for it. Okay. Now, what we deal with in kids with autism is oftentimes they regress. So I'd say it's anywhere from 50% to maybe slightly more than that, where these are kids that might be developing normally, maybe speaking okay, having good social interaction, and they can lose it and regress. And so one of the things that can cause regression and been reported in the literature are seizures. So there's about 40, 50 studies last time I looked in the literature on seizures and speech regression. About half the studies showing it can, half showing it doesn't. So if you have a child who early on loses speech or regresses, one of the things that can sometimes do that are seizures. Mitochondrial dysfunction and other deficiencies, which we deal with a lot with autism, also can do this. And both mitochondrial dysfunction and these deficiencies, especially folate, can be a cause of seizures. And so sometimes when we treat mitochondrial problems or folate, we might actually treat the cause of seizures too. Okay, so we have seizures, and then there's this concept called epileptiform activity. Epileptiform means the form of seizure. So when you see the EEG, it may not meet the criteria of a seizure in that it may not be as long or as strong as a seizure, but they're kind of in between normal and seizure activity. They're abnormal, they shouldn't be there, and you'll find them in about 60% of kids with autism. We'll talk about that in a little bit. And you find them in about 1 or 2% of typical people, and those are people that usually have epilepsy. So the discharges are not normal, they're abnormal. They occur so often in autism, 60 to 80% will have it at some point in their life, that some doctors, you hear them say, well, this is kind of normal for autism, But we also know that these things can maybe contribute to autism symptoms as well. So you guys, I'm sure know this, but what are seizures? Where they're episodes that disturb brain function. So you get these abnormally excited electrical signals that disrupt the smooth running pattern of the brain. And so if you have 2 seizures without an obvious explanation, then we would call that epilepsy. So you kind of get one free seizure, so to say, without getting diagnosed with epilepsy. We're going to talk a little bit about how in autism, if you get one seizure, you can probably get a second one almost guaranteed, and we might treat sooner. So this is kind of supposed to be showing the brain with the signals going to different areas of the brain. And this is a very coordinated process. There's nothing chaotic about it. So one area of the brain talks to another area of the brain and so forth. What we get with the seizure is just get an area of the brain that will shoot out signals indiscriminately. So it'll be very chaotic. I usually tell parents it's kind of like an electrical storm. So instead of sending 1 or 2 signals, you got an area of the brain that's just shooting signals all over. And that can cause other areas of the brain to fire, and then you get the abnormality. So if that seizure activity reaches the motor cortex, the area of the brain that controls arm and leg movement, you might fall down and shake all over. If it reaches the speech area, you might just have poor speech. It might go to the frontal lobes, and you might just have a staring spell, where someone might just, that might have been a little seizure. You don't know, I mean, it could have been daydream too, right? So sometimes you can get that. So what do we get with seizures? Well, they can be subclinical. Some people call them silent seizures, where you could have a seizure in the speech area of the brain, but if you have poor speech, you're never going to know it, right? Most of them don't look at a patient or someone who has poor speech and say, I wonder if they're having seizures that's causing the poor speech, right? And in autism, that's one of the core features is speech delay and speech problems. You could have staring spells. Those are pretty common. The interesting thing with the staring spells, at least what we see in autism, is that they don't tend to correlate with the EEG per se when the kid is staring, but when you get the seizure met to the proper dose, the staring spells usually go away. So sometimes we use staring spells as a marker for maybe there's still seizure activity going on. You can get rapid blinking. Actually holding your hands over the ears can be a seizure. Unprovoked crying episodes. Aggressive behaviors out of the blue can be seizure related. Obviously, you can lose consciousness and have a violent convulsion. So if someone falls down and shakes all over, you know what's going on at that point, right? And some people have an aura where they can kind of feel it coming ahead of time. So if we look at, again, autism, again, these seizures are generally 1-2% of the general population. About 25 to 30% of children with autism will develop seizures that you can see at some point in their life where they might fall, shake all over. And about another third will have these subclinical discharges where there's abnormal brain signals that kind of look like seizure, but there's nothing on the outside that tells you they're there. So for example, you could have these discharges in the speech area of the brain, have poor speech, but you're not normally going to think that's like a seizure-related thing, right? Whereas if the child fell, then you get and shook, then you go, okay, something's going on. So about a third will have a normal EEG. So at least in autism, we're dealing with 2/3, maybe even up to 80% of kids with autism will have some type of abnormal EEG. So in kids with autism, we always get an EEG done to screen for this. And then we find about 20% of kids will have EEG slowing. So the EEG measures the signals in the brain to see if there's chaotic signals, abnormal signals, and then also measures the power. So some kids will have low power. In other words, the signal in the brain is not as strong as it should be. And we can see that in some kids as well. So the EEG picks up that in addition, which is nice. So potential causes of seizure. So, certainly could have brain malformations. Mitochondrial disorders are a common cause of seizures, at least in kids with autism. Cerebral folate deficiency, we have low folate in the brain. So the mitochondrial disorders and cerebral folate deficiency are treatable, and sometimes by treating those well, you can actually lower seizures and help with seizures. Inflammatory processes, you can have kind of rare metabolic disorders too that we'll screen for. Obviously, you can have genetic disorders as well. So we have a child who has seizures or epilepsy, we're trying to figure out what the cause is. Some of them we can't really treat right now, like genetic disorders might not be able to do much about. Brain malformations we can't do much about, but we certainly can treat inflammation and cerebral folate deficiency and mitochondrial disorders. So these are the things we're screening for because these are testable and treatable.
Sorry, another question.
Yeah.
For the mitochondrial disorder that can cause seizure,
Yeah.
what kind of seizure is it? Is it like a tonic-clonic or?
So the question is mitochondrial disorder, what type of seizure? It can be any type of seizure. It could be a generalized, it could be spikes, it could be any number of things. Yeah. But another thing we see with the mitochondrial disorders is oftentimes they're slowing the brain because the mitochondria in the brain creates the power for the energy, and sometimes the brain's a little bit slow. Yeah, question?
So my granddaughter is autistic and has the mitochondrial disorder and the cerebral folate
Yeah.
deficiency. At 2 years old, she had a video EKG done.
Yeah.
Came back normal.
Yeah.
When would you recommend to get another one done? Because she does have a speech issue.
Yeah, so the question is, a child with autism, mitochondrial disorders, cerebral folate deficiency, how often do you EEGs? I usually do them every 2 or 3 years as surveillance, just to monitor. Definitely do them when they hit 10, because after 10, seizures are 2.5 times more likely because of autism as they get older, maybe through puberty. And the other thing I find is you really need to do an overnight EEG because the sleep activates the discharges. You can see them better during sleep. And it really depends on the neurologist reading it, okay? So most neurologists, they don't really care too much about spikes. They're more into, is the kid having a seizure? So they tell the computer to flag areas that are suspicious, but they might say, just show me the big areas. They might not might not look for the discharges. So I've had a lot of EEGs over the years read by neurologists that we got reread, mainly through Dr. Millett, who does our EEG readings, and sometimes they'll find spikes that the doctors don't find. So sometimes it's who's reading it too, because nobody watches 24 hours of EEG. They tell the computer to flag areas. And so they might say, show me mild areas, show me significant areas. And if you don't have an overnight EEG, that can miss it too. And we'll talk about this as we go along as well. So have high index of suspicion. What I see in some kids is they'll actually have a seizure at some point. And what I tell parents is it's kind of a blessing in disguise because now we know that your kid has something going on there we can treat. Whereas before, like, is it there? Is it not? We do the EEG. Sometimes they don't pick it up right. So I know it's tough to see a kid have a seizure, but sometimes that allows you to know, okay, there's something we need to do here about this. Okay, so you guys know this, EEG measurements. So you put the EEG on the scalp, glue it down. And these are my 2 kids up here. And this is EEGs they were doing when they were younger. Okay, so how long does it take on the EEG to see your first problem? This study showed it takes almost 5.5, 6 hours before you actually see the first abnormality on an EEG. That means a 1-hour EEG is, I'm not going to say it's worthless, but it's close to worthless. It's just not long enough because these are kids with discharges, known seizures, known discharges, that the first abnormality on the EEG was about 5 to 6 hours in, okay? And what we know in a lot of kids is that most of the discharges and seizures can occur at night because sleep activates them. You can see it better. That's why we always do the sleep overnight EEG. If you did a 24-hour EEG, you picked up 85% of the seizures. If you went out to 48 hours, you picked up 95%. If you went out to 96 hours, you get another 5%. So you get a little bit higher yield by doing 2 or 3 day EEGs, but those can be difficult in some kids. So the overnight one, 24-hour or close to that, will pick up 85% of seizures. So if you have a high index of suspicion, there's a 15% chance you're missing it. Okay, you go to 48 hours, now you only have about maybe a 5% chance you're missing it. Okay, so I have kids all the time that the EEGs come back normal. I'm like, really? I'm sure this kid's having something going on. Okay, there is a scan we do, which is called a SPECT scan. I don't really have a slide about that, but that's a scan that looks at brain function, and that can pick up seizures that EEGs can miss. So Sundays will do a brain SPECT scan. And the closest place in this area is Dr. Amon at Costa Mesa, so he does these SPECT scans. And I've had a number of kids over the years that EEGs were normal, that I was really strongly suspicious they're having seizures, and the SPECT showed seizure activity. So you can do further testing beyond EEG if you need to. Yes, question? SPECT scan, so it's SPECT. It's a CAT scan that uses a little bit of a radioactive tracer that the brain picks up. And it looks at brain activity. So it can actually show you different brain patterns, like you can see traumatic brain injuries, because it will show up as very low activity. you can see seizures that show up at high activity, and it shows you location very well. So actually, it's used prior to epilepsy surgery, typically to find the exact location of the seizure when they take the brain tissue out, so it can find location better. It does involve putting an IV in, injecting a radioactive tracer, which is very mild, and then scanning the brain for about 20 minutes in a scanner, kind of like an MRI, only look at the brain function. Yeah. Yeah. So the MRI and CAT scan is like you open the hood of the car and you look at the engine and, okay, engine looks okay, nothing's cracked, I'm not missing anything. The spec is like, okay, turn the engine on and see how well it's working. So it kind of shows your brain activity. So we can see, very decreased activity in kids who have like a near drowning or a carbon monoxide poisoning, or if they had a brain injury, you can see that too, and then you can see location seizures. So you do sometimes get a lot of other information out of it. Okay, so what percent of kids with autism have these abnormal EEGs? Well, this is a study looking at almost 900 children, and in the study, about 61% had an abnormal EEG. This is on 24-hour EEG testing. Okay. This is another study. It's showing 64% had abnormality. This is 206 patients with autism, so not quite as big a study. And the kids that had seizures had more intellectual disability. This study was interesting because it showed being taller was more likely to be associated with seizures too. So the taller the kid is, the more likely to get seizures. Not sure why, but we think when you grow quickly and get tall, that your brain probably goes quickly too, and maybe kind of gets a little bit, I don't know what the right word would be, stretched, or just kind of grows quickly, and so maybe you get more abnormalities and so forth. And this is a study of over 1,000 kids with autism. This is out of Japan, showing about 85% of them had these discharges. And that kids that had discharges had lower IQ. So pretty high percentage, and we're talking about 60, maybe even 85% of kids with autism at some point in their life can have these abnormalities. That's why every kid we see with autism, we recommend getting EEG done, not just a 1 hour, but an overnight EEG at the very minimum. And repeat it if you're suspicious, so might do one every couple, 3 years. This is surveillance. I've had kids over the years where I've done EEG every 3 years. They're normal. And I had one kid who was in his early 20s, normal EEGs all every 3 years or 2 years, and then had a seizure. So sometimes it just happens, but we try to screen for them with the EEGs. Okay, this is a really important study, I think, because a lot of times when a kid has a seizure, you sort of get a free one. Like you get a seizure, you go to the ER, okay, you had a seizure, we don't know why, the tests don't show anything. Let's see if he gets a second seizure, then we'll treat if that, because that'll be epilepsy, right? What we know in kids with autism, this is a study on 141 patients, that within about 7.5 months, there was a second seizure in 92%. So you're almost guaranteed to get a second seizure if you have one already. So in kids with autism, when they get the first seizure, a lot of times we'll start treating them because we know they're probably going to get another one. And it's kind of hard to tell a parent to go home and wait for another seizure, and there's a 92% chance it's going to happen, right? If it was 30%, but 92 is pretty high, right? So, so a lot of kids will think about treating even if the first seizure and not wait for the second one. All right, there's this interesting correlation between autism behavior and seizures and discharges and so forth. So this is a study looking at sleep and epilepsy, and they're reciprocal. So when you have seizures or seizure-like activity at night, it tends to disrupt your sleep. So you tend to wake up or have very poor sleep. So one of the most common causes we see in kids with autism before sleep are sometimes these discharges, abnormal EEG findings, and so forth, because basically the discharges will knock you out of sleep or make your sleep not as good. When we do our EEGs, we do a 24-hour EEG, and the nice thing is we get sleeped out off that too. So we get stages of sleep and so forth, and we can see when the discharges are occurring during what types of sleep and so on. This is a study looking at over 2,500 kids with autism, showing that kids who had epilepsy were more irritable and more hyperactive. Another study, this is 101 patients, finding that kids who had seizures or abnormal EEGs were more likely to have self-stimulatory behavior, repetitive behaviors, and more likely to have aggressive behaviors. For example, I had a patient that the parents were at home doing EEG, and the child started jumping up and down, flapping his hands, making noises, and they're told, push the button if you see something unusual. When they push the button, that kid was having discharges at that time. So the discharges were making him have these autistic kind of behaviors. So sometimes the stems, the repetitive behaviors, have a cause, and it might be seizure activity or seizure-like activity. Another study here, so 182 patients, showing that the abnormal EEGs were associated with social functioning problems, because in autism we have a big problem with social communication, of course. And this one I mentioned kind of earlier alluded to that in kids with autism and epilepsy is about 2.5 times more likely after age 10. So once you hit 10 and go over, the seizure chances go up by about 2.5-fold, which is pretty high. So anytime we had kids that have puberty, we start thinking about that. And in the study, also found that epilepsy was associated with lower cognibility, poor language, adaptive functioning, a history of regression. So anytime we have a kid who regresses, we always think that maybe seizure could be part of what caused it, and more severe autism symptoms. And there are studies, which we'll get to in a minute, showing that if you treat the discharges, the behavior can get better too. One of the big things we see is this aggressive behavior, especially aggressiveness out of the blue for no reason can be associated with seizures in kids with autism. So aggression can be very difficult to treat, and sometimes people end up on antipsychotics or really strong meds that have a lot of side effects, where maybe if you treat the underlying cause, i.e. epilepsy, then you won't need those strong medications maybe. This is a study looking at over 200 patients with ADHD, showing about half of them had abnormal EEG findings. So some patients with ADHD will have microseizures or discharges in the attention of the brain and kind of lose attention, zone out, maybe lose a few seconds. You might have a little bit of obsolete seizure. So you might know, maybe you've seen this in yourself or you've seen people you talk to, where you're talking to them and then they kind of daze off a little bit and they come back and they go, what were we talking about? You know, it's like that could have been a seizure. Doesn't mean it was, could be daydreaming. But about half the patients with ADHD can have these abnormal EEG findings. So even in patients with ADHD, sometimes we'll screen for seizure activity or discharges as well. This is just kind of looking at, again, regression. So there's about 20 or 25 studies showing this in literature. So this is a patient who had a severe language regression at 25 months old and turned out to have abnormal EEGs, was treated with ACTH, which can treat seizures, and had a significant improvement in language. And there's probably about 10 or 15 studies in literature showing that steroids can increase language in kids with autism too, especially in kids who have seizures. This is a patient, again, looking at kind of the regression. So again, kids that are developing normally and regress, that again, epilepsy can sometimes be more common in kids who regress. So in some kids, they can have onset of seizure at 2 or 2.5 or so. You get the developmental regression, and it could be seizures that's doing it. So if you get a seizure in the speech area of the brain, you might lose speech. So anytime we have a kid who regresses, we start thinking, okay, this could be having abnormal EEG findings. This is the best study to date that's looked at this so far, looking at the correlation between behaviors and abnormal EEG findings. So this study found that in patients with autism, about 40% had abnormal EEGs. Now this is in 69 patients, so not a huge study. But they found kids who had the abnormal EEG, so discharges, seizure-like activity, had more severe autism, more hyperactivity, more anger outbursts, aggressive behaviors, destructive behavior, motor stems, intellectual impairment, language impairment, self-harm. So we have a lot of patients who have language impairment and stems and aggressive and self-harm. So you can imagine you can put that kid on, medication to suppress the behavior, like an antipsychotic. But if the EEG is causing it, it would be better to treat the EEG, right, and do that first. And then you can always go to the medicine if you don't get enough improvement. Okay, so kind of shifting into treatments. Any questions you guys have so far? Or shout them out if you got them. Okay, so this is looking at a study of 22 patients. This is a study that Dr. Fry did. He talked to yesterday. He's part of our clinic in Arizona, so he's a neurologist. And so we had these 22 patients who weren't responding to standard treatment. So they weren't responding to therapies like ABA. They had no obvious signs of seizures and so forth, but they had these abnormal EEGs. So they had these discharges that we've been talking about on the EEG. And so they treated 20 patients with medication, seizure medication. And within one visit, so about 6 or 8 weeks, about 70% of them had improvement. So these are kids that have discharge on the EEG, but no obvious symptoms from the discharge on the outside. And kind of what I see in some neurologists, not all, but some of them are like, okay, you have these discharges. We don't really see any signs of seizure. It's not really a true seizure. You don't really need to treat it. If the kid gets a seizure, maybe we'll treat it. That's kind of the old way of looking at it. Now we know from newer studies that if you treat these discharges, that sometimes you can get improvements in behavior and speech and brain function and so forth. So there's still a lot of doctors that will find these discharges and go, well, it's kind of abnormal for autism. A lot of them have this. We see it all the time, but we don't see that, it does anything as far as treatment. If you never treat it, you never get to see an improvement. So you never treat it, so you don't see an improvement. So you never treat it, you get in that cycle, right? So I treat the discharges all the time, and I see a lot of kids that get better. So that makes you want to do it again, right? So if you don't treat the discharges, you won't see that. You won't get that positive feedback. So this is from the same study. Again, 70% of kids improve with one clinic visit. These are kids that are not improving. They're kind of stuck. They're not making progress, but have abnormal EGs. When they bump the dose of the med up a little bit, they got another 10% improvement, and about 5% had mild improvement, limited improvement. So about 85% of kids improved with seizure medication to treat their discharges. This is another study looking at levetiracetam. This is the med I use most commonly in autism because there's quite a few studies on it now in autism. This study took patients, 70 patients with the discharges, so seizure-like activity, put half on levetiracetam, half weren't treated, and they all got standard educational therapy and so forth. And the kids that got levetiracetam had improved behavior and cognitive functionings. Yep. That's Keppra, yep. So the big, the Kepra's famous for what? Kep rage, right? So the aggressiveness you get from that. That's about 15% of kids. And I find that kids that are not aggressive or irritable tend to do okay with Keppra. Kids that are aggressive, you might be asking for trouble. If you get B6, or we use P5P, the active form B6, with the Keppra, that usually prevents it too, can be really helpful in preventing it. And there's quite a few studies on Keppra showing that it can lower aggressiveness too, so it can go either way. So I tend to use this one a lot because of these type of studies showing improvement in brain function and so forth. And it's generally pretty well tolerated by most kids. And it's pretty benign as far as side effects. Doesn't affect, doesn't depress brain function too much or cause mitochondrial problems. Like some seizure meds like Depakote and stuff can actually cause mitochondrial issues. Yeah.
I know this might be a weird question, but like, because girls people can know autism, and also their camera seems that way, whereas you're crazy. Do you have any insight on why that?
Yeah, the question is about a kid who had a seizure and then went on Keppra and got worse, right? We see it occasionally. It is known that some seizure meds can make seizures worse if you hit the wrong mechanism, So all these meds are working through different mechanisms. And so then you might switch to a different med. Sometimes the dose is not high enough. So sometimes you're going to get more seizures anyway, and the Keppra dose is such a small dose that it's not really making a difference either way, and then you need a higher dose. Although it's sometimes hard to develop people to go higher in the dose if it's causing problems, So, but I see this a lot in kids with autism that certain medications, if you use a low dose, they get a little bit worse. If you do a higher dose, they get better. It's almost like the lower dose. I don't know how to explain it other than they kind of fight it. Maybe the med makes them a little drowsy or kind of slow or tired or whatever because it's calming them down, and they kind of fight it. And then if you go higher in the med, they kind of can't fight it, if that makes sense. So I do have some kids that on low doses of these things, they don't do as well. So with Keppra, I'll typically go, unless they have severe seizures, I'll go to like a 40 milligram per kilogram dose, which is kind of right in the middle, and not do the lower doses because some kids do better on the higher doses. But yeah, if you have a kid who's doing poorly on the seizure med, you may need to switch.
You've been on every seizure med.
Yeah.
Everything made it worse. Like, it just didn't seem like that. I would say that.
Yeah.
But like, some people get to like 5.
Yeah.
Now every medicine under the sun is 60,000 less.
Yeah, I mean, that's a tough case where every seizure med is making it worse. But then what I would do in that case too is make sure you're not missing anything like a mitochondrial disorder or folate issues, because if you have low folate in the brain or a mitochondrial disorder, which we'll talk about here in a minute, there may be no seizure med that's going to make that better until you treat some of the online issues. So.
Like getting this CFD tested.
Yeah.
And they kind of like wrote it off at the children's hospital.
Yeah.
That's not a big issue. Obviously, I know that's an issue. But then like, as far as like looking at the EEG, they're like, okay, let's try. Like you have issues with the B6 and B12
Yeah.
and the folate.
Yeah.
But then they're like just trying to treat it with a one dose thing and try to look at the EEG, but you would potentially need longer time, right?
Yeah, we find, so questions about length of time, for these things to work. So we find that with, treating cerebral folate deficiency, low folate in the brain, or mitochondrial disorder, what I see is it takes about 2 years for those treatments to really kick in and have an anti-seizure effect. And so you may need a seizure med while you're waiting for that to work. I had a patient from Vegas. She was on 3 seizure meds, having intractable seizures still. She got spinal tapped by her neurologist. So normal folate level in the spinal fluid is 40 to 120. Hers is 44. So neurologist said, it's fine. You don't have to worry about it. I'm like, 44, normal's 40. I'm like, that's pretty low. So we put her on leucovorin, which is, we'll get into this in a minute, which is treatment for CFD. And her seizures went away completely, and she came off all her seizure meds. Now that's results not typical, right? That doesn't always happen. But in her case, the main cause was this low folate in the brain. And it really wasn't treated properly. So once we treated it, there was a big improvement. So the problem with the cerebral folate deficiency is, are you going to spinal tap every kid to look for that, right? So if you have intractable seizures on many meds, you might, Sorry, Don, say. Okay.
Is there a point of like no returning that, like you should have treated it when you were 5?
Yeah, so you're talking about CFD, yeah, we'll talk about a little more in a minute here, but yes, the longer you wait to treat it, the harder it is to treat. So unfortunately, studies show if you wait until about 7 to treat it, you're not going to get as much as if you treat them, say, at 3 or 4. So we try to screen for this rapidly. And there's other tests we do too, which I think we're going to get into in a minute when we talk about CFD. Oh, here it is. Okay. So this is a study on looking at CFD in patients with autism. So this study was done out of Switzerland. In Switzerland, they have a sort of a medical system where the worst of the worst gets referred to the tertiary care. Kind of like people go to the academic universities here is like the final place to go. And so this is at one of those type of places where it's the final dumping ground or final place everyone goes to get treatment when nothing's working. So you had 25 patients with early onset. Early onset means they had autism kind of from birth, so they weren't regressive. They were kind of autistic from birth, and they were low functioning. So it means they're very severe autism. And some of them had neurological deficits, like some of them had ataxia, trouble walking, some of them had seizures, some of them had other neurological issues. And they measured what's called an antibody to the folate receptor. So when you get folate from meat, green leafy veggies, you can supplement it. It comes from the stomach into the blood. From the blood, it goes very easy in the body, like liver, kidney, muscle, and so forth. But it's got to go in the brain. You have a blood-brain barrier around the brain that protects the brain, which is great, but doesn't allow the folate to go directly in the brain for the most part. So it goes into the brain through the folate receptor. The folate receptor is attached to the brain, but poking out the blood, and the folate in the blood will attach to the receptor and then go in the brain. That's what normally happens. Some kids make an antibody that it's abnormal, they shouldn't make it, that actually blocks this receptor. So it makes it hard for the folate to attach to the receptor and then to go in the brain. So these antibodies are associated with low folate in the brain because they block the uptake of folate in the brain. And the higher the antibody level is, the lower the folate in the brain is. So we can measure these antibodies in the blood. We can do that now. And then once the folate does attach to the receptor, you have to push in the brain using mitochondrial function. So again, if you have a mitochondrial problem, you can have low folate in the brain as well. So we oftentimes will screen for mitochondrial disorders in these kids as well. And so in this study, they found that these 23 out of 25, so over 90% of patients, had low methylfolate in the brain. Now, we don't find 90% of kids with autism with low folate in the brain. It's probably more like 30, 35%. However, these were the most severe kids with autism. So maybe you could say the really severe kids with autism have a lot of neurological deficits, might be more likely to have this low folate in the brain. In 19 of the 23, they were able to explain the low folate in the brain with the antibodies because the antibodies were positive, but 4 patients, it was low in the brain for some other reason, maybe mitochondrial disorder or something like that. And so they gave orofulinic acid, which has been in the news recently because President Trump talked about it. The prescription form is called leucovorin. We generally do the prescription form because otherwise, if you did the supplement, you might have to give a patient 100 capsules a day, which is not feasible and would be too expensive anyway. So we use this prescription leucovorin, which most insurance will pay for. And what that does is it goes in the brain through a different pathway. So instead of going through the folate receptor, it goes in the brain through the reduced folate carrier. It raises the folate level in the brain. And in this study here, they found with 12 months of treatment that there was partial complete clinical recovery after 12 months. So some of the kids dramatically improved, which is kind of a big deal because these are, again, very severe kids with autism. But they had low folate in the brain. Yeah.
Is it possible to be tested for the low folate, the antibodies?
Yeah.
And maybe maybe it wasn't accurate, maybe it was one of those.
Yeah.
Would you recommend, just to be on the safe side, to test again?
Yeah.
Maybe with a different provider or whatever?
So the question is about folate receptor antibodies. What if they're negative? Could it be a false negative? Yeah, it could be. Dr. Quadros at the State University of New York, who discovered these antibodies like in the late 90s, he's found that some people are intermittently positive. They'll be negative, positive. And then we know from studies too that in this study at least, 4 of the patients had low folate in the brain, but their antibodies were negative, which means there can be other mechanisms, maybe mitochondrial problems. So you could argue, maybe you just treat the kid regardless, especially if they have seizures, to see if it's helpful because this fulinic acid can have an anti-seizure effect. But certainly if you're positive for the antibody, and the higher the level is, the more you need the leucovorin, so the more higher dose you'll push it sometimes. So it does help you with dosing a little bit. The other thing is that one of the things that makes the antibody to the folate receptor positive and go up is milk, cow's milk. So usually elimination of milk makes this condition better too. So it turns out that a glass of cow's milk has cow folate receptor in it. So the folate receptor is attached to cow's brain, which is 91% similar to human folate receptor, is floating around the milk. You drink the milk, that receptor goes in your blood, and you make antibody to it, which cross-reacts with your own antibody. So being milk-free actually can have an anti-seizure effect if you have these antibodies positive. So usually if the antibodies are negative, we don't necessarily go milk-free. If they're positive, then we'll usually go milk-free. What do you get from milk? You get protein and calcium, right? So you can get protein other sources, and you can supplement calcium other ways. All right, so moving into kind of some of the other treatments. So this is an article that we were involved with a little bit over 10 years ago, looking at all the different types of treatments for seizures, not just medications, but also looking at nutritional supplements and diets and so forth. So there's pretty good evidence for the ketogenic and modified Atkins diet. I mean, obviously it's not the easiest thing in the world to do, but there's some pretty good evidence for it. Maybe even neurofeedback might help, immunomodulation might help. And then other things that may be beneficial, there's some evidence that supplements like carnitine, multivitamins, and acetylcysteine might be beneficial. Definitely for mitochondrial disorders, those can be helpful. Folinic acid for the low folate in the brain. Things like magnesium, B6, fish oil, even a gluten-free casein-free diet have some anti-seizure effects, so does zinc and carnosine, some anti-seizure. Again, if you have a severe seizure disorder, you're not going to be able to control these type of things, but these might be helpful as adjuncts to kind of get a little bit of an anti-seizure effect as well. Other things that potential, for anti-seizure would be certainly medications. Steroids are anti-seizure. A lot of the meds being developed with seizures now are kind of steroid derivatives. IVIG can have a nice anti-seizure effect, so some cases we'll try to use it for that. Hyperbaric oxygen does have some anti-seizure effects. Again, if you do that, you want to do it with someone who's knowledgeable and kind of knows what they're doing. Obviously, vagal nerve stimulator can be helpful for some patients. Surgery, of course, which we try to do as last resort. These are some of the supplements that might have an anti-seizure effects. So taurine, B6, mag, omega-3, GABA, DMG, carnosine, folinic acid.
Values of each one.
Yeah, you can use the standard doses that are on the supplement bottle, but obviously talk to your doc too, because but most of these are pretty benign, so you're not really going to cause a lot of harm. I mean, some of them like carnosine can make it a little more hyper. Folinic acid, you're usually going to get leucovorin prescription from your doctor because you want to do kind of higher doses, right? But it is available as a supplement too. And supplements are generally regarded as safe for the most part, yeah.
So I can really think it's I mean, you can want supplements, but like the did test like to be like to see that the category is lower. I think it was like 30.
Yeah.
But we checked something. So like starts low with the clinic, but it caused an increase in seizures. So do you think I can go even higher? Or?
Yeah, I mean, sometimes we see, so the question about folinic acid causing increase in seizures, sometimes we do see that. Not sure why. It might be that when you have low folate in the brain, everything's kind of underactive and not working well. And so when you give folinic acid to an area that's seizing, maybe now it can function stronger and have more seizures, and then over time it kind of settles down. So a lot of times we'll start with a low dose, increase it slowly over time. But if you have CFD with spinal fluid in the 30s, you're probably going to need 4 to 6 milligram per kilogram of leucovorin. What they do in the CFD studies is those spinal tap kids show they have CFD, treat for 6 months with leucovorin, spinal tap again, and they'll keep increasing the dose until they get the dose at the right. And so in some of those studies, they'll go as high as 12 milligram per kilogram of leucovorin. So that's a massively high dose. But a lot of kids, you need a minimum, if you have that low folate in the brain, you're going to need probably 2 to 4 milligram per kilogram. So you can kind of calculate the dose out and talk to your doctor about it. But yes, when you first start folinic and carnitine sometimes, you can get an increase in seizure, but then it kind of settles out over time usually, and then it starts having an anti-seizure effect.
Like has an uptake. It's like every he's like all of a sudden. And then I
Yeah.
have more seizures develop it, but then I do like messing around with doses. I definitely get a decrease on like everything that I need when I use it.
Yeah.
But it's just like playing around with things.
Yeah, so the question, the kids has lots of seizures and it's hard to manage and hard to know what's doing what, right? So, more questions? I thought I saw another one. Okay. So kind of some summary stuff. Some of this we talked about, some is maybe we didn't go over too much, but at least in autism we see 2 age peaks, 4 to 6 years old and again after 10. Not that you can't have a seizure at 8, but you tend to see the most between 4 and 6 and after 10. Again, the prevalence of these discharges in autism is at least 60%, maybe 80%, depending on the study. Children over 10 are more likely to get more seizures. They're more likely to have STEMs, aggressive behaviors, irritability, hyperactivity. Kind of talked about some of those correlations. Seizure-like activity can impair attention in some people. The sleep is reciprocal, so when you get a lot of seizure activity at night, you can have poor sleep. So if you have a child with poor sleep, think about the possibility of seizure activity because they're more likely to occur during sleep than during daytime. Tall children are more likely to have seizures. Again, we talked about the 90% of kids will have a second seizure within 1 year. And oftentimes, because of these discharges, seizure-like activity will improve with seizure medications. So we don't have to wait for them to have a seizure. We could treat the abnormal EEG. So we have a lot of patients that come in on seizure meds, have autism. Sometimes there are other conditions too. No seizures that they can see. But I'm like, well, when was the last time you did an EEG? Well, we haven't done one in years, so why not? Well, the neurologist doesn't think we need one because we don't have any seizures. I'm like, okay, that's fine, but maybe you have these hidden discharges or things you don't know about that might be causing your kid not to speak well, poor attention, and so forth. And so we'll do the EEG. And so even though not having visible seizures you can see, the EEG can be abnormal with the discharges. The problem with, of course, treating that is you'll need more medicine to do it, right, to kind of treat it, to get the discharges under control. But we now know in about 80% of kids with autism, if you get the discharges normal, get them under control, that you can get more speech, cognitive functioning, less behaviors, and so forth. So again, we'll do EEGs even in kids that are seizure-free on seizure meds, especially on an EEG in a few years, just to screen for this, because even though they're on medication and not having seizures, you can see they may be having sort of these invisible, hidden type discharges that you could then further treat. You can get specific syndromes. They're not super common. Again, these are very common. And then there's some studies that show the location of the discharges correlate with symptoms, which makes sense. Discharges in the speech of the brain, poor speech. Discharges in the attention of the brain, poor attention. Seizure activity in the area of brain control, arm, leg movement, fall down, shake, right? So a lot of patients, parents, people don't quite understand this concept. Like they think if you're not falling down and shaking, you can't be having any type of seizure or seizure-like activity, right? But anything that your brain can tell your body to do, a seizure can mimic or impair, right? So the brain tells you to speak. Well, if you have a seizure in that area of the brain, you may not speak well. The brain tells you to, move your arms. So if you get a seizure there, then you fall down and shake, right? So the location is it's like real estate. Location is everything, right? So again, the EEG can give us location as well. We didn't talk about this, but this is important as well. So this is a study here that showed in kids who have discharges, kids with autism with discharges, if you don't treat them, about half of them will develop seizures that you can't see. So when we have an abnormal EEG with discharges but no seizures, we'll treat it for two reasons. One is we may end up preventing a seizure, which would be great. Of course, if you prevent a seizure, you don't know you prevented it, but you may have. And then number two, you can get better brain function, better speech, better cognition, better behavior, and so forth. That's really what we're going after mostly, but we also would like to prevent a seizure too. Now, you get these kids sometimes that have abnormal EEGs, and you put them on seizure medication, and they're fine for a while, and then you stop the medication, they get a seizure, and like, oh, the seizure med caused a seizure. Well, in that case, what might have been happening is you would have had seizures already, but the med prevented it, and then you stopped it, and now the seizures are unmasked. So a lot of times we see that too. And so some parents, you prevent a world of hurt because you end up preventing seizures that they otherwise would have had, but you don't know you prevented it, right? So, okay, so take-home message, we always do at least an overnight EEG. We know that the shorter EEGs can miss it. In my opinion, a 1 or 2 hour EEG is almost worthless. Some insurance is required for whatever reason. The problem with that is if it's normal, you need the 24-hour EEG to make sure it's truly normal. If it's abnormal, you need a 24-hour EEG to rule out like the seizure activity that can occur all night long, like ESES. You need to rule out some of those bad things. So either way, if it's normal, abnormal, 1 hour EEG, you still need a long one. So you might as well cut to the chase and do the long one if you can. But I know a lot of doctors still do these 1 or 2 hour EEGs, and if you pick up an abnormality there, you probably have a really abnormal 24-hour EEG, right? Because you're having to pick it up at that 1 or 2 hours. So I got lots of kids that have a 1 hour EEG. Oh, we did it, it's ruled out. I'm like, not really. You need to do a longer one. Consider treating any abnormal activity. So even discharges you might consider treating. And you might repeat the EEG, especially if normal in the past, especially if you're suspicious. So sometimes we'll do an EEG every year or two because we're suspicious and so forth. Question?
If you had an abnormal EEG, you have seizures, you still need to repeat it?
So the question is, you have abnormal EEG and you treat it. So what we do is we have an abnormal EEG, we treat it, and then we repeat the EEG soon. So some patients we've done like 3 or 4 EEGs in a year because we adjust the med, EEG, adjust the med. It's kind of like when you take a blood pressure pill, you take a blood pressure, it's still high, okay, increase the dose, right? The problem with the EEGs are just a little bit harder to do. It's not like it's easy as taking your blood pressure. But we'll treat the EEG abnormality with the med that we think is the right med at the right dose, and then repeat the EEG after they've been on the med for at least a couple months, make sure it's kind of kicked in. Well, then we make sure it's better. So we have a lot of patients where the EEG is a little bit better, but still abnormal, and then we bump the dose higher, add a second med, and so forth. So we try to do that until the EEG becomes normal. And then after that, we'll do an EEG maybe every 2 or 3 years as like a surveillance, just to make sure. If kids gain a lot of weight, we'll bump the med dose maybe based on weight. I always check blood levels of the seizure meds. So you do it in the morning before you take the medication to get a trough, because at least in kids with autism, we find that a lot of them are in these sort of really high dose based on weight doses, but in the blood, it's almost below the range or on the very low end. So it seems like some of these kids don't absorb their meds well, or maybe they use them up quickly. So we have a lot of kids that are on kind of these high dose meds that the blood levels aren't as high as you would expect them to be. So sometimes you can adjust the medication. So we have some kids that go above the max dose. Again, you obviously work with your doctor on this, of course, because their blood levels are not really that high. So we look at blood levels, which can be really helpful to know how much room you have to move up. Obviously, if you're on the high end, you might need to back down on it some. And then we do the EEG liberally. So we order them frequently, every year or 2 or 3, as surveillance. Or again, if something changes, like, hey, this kid's doing some weird activity, something like that. I find that teachers and therapists are pretty good. If they come to you and say, I think your kid might have had a seizure, they're almost always right. So sometimes you'll hear that, like a teacher goes, oh, your kid did something weird, I think it might have been a seizure. And you go, whatever. But what I see is that they're usually correct, because they have a lot of experience. And some parents get pretty good, too, at recognizing as well, like my kid's staring off, blinking, doing weird stuff, So any type of change in behavior might mean you need to get another EEG, too, to screen for that. Yes, question?
Okay, on your earlier slide, you mentioned unprovoked crying episodes.
Yeah.
And that's something that we consider having 2 years back.
Yeah.
Is there more research on that?
Yeah, I mean, that's been shown in some studies to be a sign of a seizure. Doesn't mean it is, So a staring off is an episode we just kind of, that could be a seizure, but doesn't mean it is. It could be daydream. The unprovoked crying could be a seizure, but doesn't mean it is. Sometimes aggressiveness for no reason. Like some kids get very upset and then they cry or they're aggressive. You go, well, there's an antecedent. There's a reason they got really upset and they did it. But these kids that just cry for no reason, just boom, out of the blue, or they start hitting people for no apparent reason, you go, that might be a seizure, because what does that do? It's just kind of makes you act out, not be able to control it as well.
And then, what is the duration of the crying? What is the duration of if it is a seizure?
Potentially, so the duration might be during the seizure, yeah. I mean, it's possible, right? So basically, what we would say in that case is we don't know if it's a seizure or not, but let's do the EEG to make sure. Especially if it's a new finding, like it's change, right? So you say, okay, maybe something's going on here. So we have a very low threshold to do the EEG. Hey, my kid's doing something weird, new. I'm like, well, it could be a seizure. I don't know if it is. Let's do the EEG. So we do a lot of EEGs because we want to test and see. And we get these sometimes patients that are like, oh, my neurologist don't want to do an EEG. It's been 5 years, but they don't think we need them. I'm like, well, it doesn't hurt to know the EEG. I mean, yes, it can be hard to do it, but it doesn't hurt to do the other one. To kind of just take a look, right? So we look a lot, because if you look a lot, you find a lot. If you find a lot, you treat a lot. If you treat a lot, you see the improvements. If you don't look and you don't treat, you don't see the improvements. So you don't look, you don't treat, you don't see the improvements. It's a cycle, right? If you do see it, doesn't mean every kid we treat is going to get better, but when you start seeing that happen, like I've had kids who are nonverbal, who went on seizure medicine and started speaking in sentences, you see that enough times, you go, I'm going to start looking for that. If you don't ever see it, you're like, you never saw it happen, so you don't even look for it, right? So it's kind of how you were trained. And we try to keep up with the literature. Anytime studies come out, we kind of change what we're doing based on studies. Most doctors don't do that. Most studies show that doctors treat patients like it's a year they graduated med school or residency. They don't always keep up with the latest stuff or whatever, change their practice. So we try to keep up with the new data, new studies.
And then you also mentioned that Depakote might cause mitochondrial.
Yeah, there are certain medications like Topamax, Depakote, and stuff that can make mitochondrial dysfunction worse. So Depakote depletes carnitine and causes high ammonia in about 20% of patients. So if you're on Depakote, you really need to monitor carnitine levels and maybe check ammonia levels. And obviously, you need to check Depakote levels. Depakote is just a little bit harder med to work with because you have to check blood levels and you can become toxic very easily with it. It's a great seizure med and it's a good mood stabilizer, but it has a lot of potential pitfalls. So not that we don't use it, just have to be kind of careful with it.
What do you recommend to replace the Depakote?
Well,
Would there be a particular
yeah.
to keep him from his biting and the motrigine?
Yeah, I mean, if the Depakote is working and it's doing okay, then we would leave it alone. You obviously check the quarantine levels maybe and make sure, because a lot of kids will need quarantine when they're on Depakote, because it depletes quarantine. And then, you might check ammonia levels. But if they're on if they come to see me on Depakote and they're doing okay on it, I'm not going to just yank it off just because I don't like the med as much as other ones, if they're doing okay with it. Yeah, question here.
Yes, our grandson has LGS and he's autistic and was doing great for quite a while and had a lot of aggressive tendencies. And then things got much better and it was nice. It was very nice.
Yeah.
Then he started having an increase. So he has drop seizures, he has OPSAP seizures, he has tonic seizures. He's wonderful. No matter what, he's still wonderful.
Yep.
Now we've all of a sudden had a regression or a reoccurrence, let's say, of some seriously aggressive behaviors.
Yep.
And then they're also noticing other seizure activity, especially
Yep.
upon waking or, right before waking, things like that.
Right.
And they are really attributing that to the fact that he's 14 years old and massive amounts of hormones entering his body, apparently. But, which I guess is probably a common theory that people would.
Yeah, it's a-
kind of go, he's
yeah,
14, so,
yeah.
His parts are changing and such. But maybe more towards some of these seizure activities that aren't really being exhibited externally and so aren't being, so he's being treated for behavior rather than seizure at
Right.
that point.
Yeah, and I think everyone heard her because you have a nice loud voice. So, puberty is associated with more seizure activity, maybe because of testosterone, so at least in boys. So, we're not going to shut off puberty generally, although sometimes we use propranolol, which is a medicine that helps aggression a lot, and it kind of has an anti-testosterone effect a little bit. It might have some mild anti-seizure effect, but in that case, you might need to adjust seizure medication and try to, because the aggressiveness could be coming from seizure. The testosterone just kind of puts gas on the fire. So anything you had before might burn a little bit brighter because of testosterone, but you still have the same underlying issue maybe. So it might be seizure just getting a little worse with the hormones. So yes, you can treat that kid for behavior. So it goes back to, do you treat the behavior or do you treat the cause, right? So we do a lot of, your kid has poor speech, this medicine helps the speech, let's try it. Sometimes you treat the symptom, but ideally we treat the cause, right? So if the aggression is coming from the seizure, you try to treat that better, right? So yeah, you might need to look into that in more depth and see.
And so the initial possibly foray into that resolution is an EEG.
Yeah, to see where you're at, right? So you start with the EEG, ideally an overnight EEG. Now, some kids will have these weird behaviors every other day. You go, well, you probably want to do a 48 or 72 hours so at least you have a chance to catch that one thing that happens every 2 days or something, right? Some kids have something that happens every 2 weeks. You're like, well, you're not going to do a 2-week EEG probably, right? So, although they're not unheard of. But yeah, you would do at least an overnight EEG, maybe 48 hour if the kid can tolerate it that long. A lot of kids, we'd love to do a 96-hour EEG. It's just, you get through one night and that's about all you can get through. And the kid is like fed up and done, so you at least get the overnight part, right? So we do a lot of, not necessarily 24-hour EEGs, but we might put it on in the afternoon, take off in the morning. But yeah, in that case, you'd want to look at seizure activity. If the EEG is clean, you go, maybe it's something else, right? But I think it's good to look at that. Question over here.
Hi. I was just wondering if you have any insight on, so my son had plasmapheresis.
Yep.
And he was like a new man, seizures decreased, had
Yeah.
the best time ever, which he has multi-system dysfunction, which would make sense. But then, so we were looking into possibly doing IVIG, but the doctor who administrates that said that he didn't want to do it because you have a high chance of getting meningitis. Do you have insight on that?
So the kid responded to plasmapheresis. So that sucks off the bad antibodies, So there are some patients that have autoimmune encephalitis or autoimmune antibodies that the immune system makes that they should make that attack brain tissue and so forth. There's something called a Cunningham panel, which is pretty good at measuring some of those antibodies, and there's certain patterns on that panel that you can get IVIG covered for. IVIG has pretty good anti-seizure properties. It's hard to get insurance to pay for it as an add-on for seizure, but sometimes we'll pay for it for autoimmune encephalitis or if you have immunodeficiency, so we check the IgG level, see if the kid is low. But the IVIG, I've used it in refractory cases for seizures and it can be really helpful. As far as meningitis, everyone gets a little bit of brain inflammation after IVIG. It's kind of mild, but what we do is we give a small dose of IV steroid during the IVIG. And then some does steroids orally for a few days afterwards, and that usually prevents the problem. But meningitis after IVIG is pretty rare and pretty minimal, but it can be prevented with the steroids too. And of course, steroids have a nice anti-seizure effect as well. So sometimes we'll try, steroids in kids, although you just can't do them long term, right? So sometimes you do them short term. So like we might think a kid has brain inflammation, but we're not going to spinal tap them to prove it, but we'll put them on prednisone for a few weeks, and sometimes you'll see this big improvement in speech or brain function or cognition or maybe a decrease in seizures, and you go, you probably do have some brain inflammation going on. So we do other medications that are anti-inflammatory, like minocycline, pentoxifylline, and stuff that we use a lot in kids with autism and studied that lower brain inflammation, but they're not having the side effects that steroids have. And then the other thing I do also, which I think is good to mention, is every kid that has abnormal EG, even just discharges, I give them a rescue med. So usually one of the nasal ones. Yeah. So. Yeah. Yeah, and a kid who's got refractory seizures that's not responding to every med and so forth, you do worry that maybe you got untreated CFD, it's not treated well enough, or maybe there's a mitochondrial disorder or something else that's also treatable, that you could, yeah. 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 And some kids need, really high doses of mito support and leucovorin and so forth. So again, you have to work with a doc that is knowledgeable in that area. So, other questions? Yeah.
My daughter for 4 years was having the spikes.
Yep.
She had 3 EEGs, and they just kind of dismissed them because she was just having absent seizures.
Yep.
So for 4 years, I didn't know, I didn't research it.
Yep.
I tried to do things for her, but she also woke up every 2 hours every single night.
Yep.
It was like an infant until she was 6 years old.
Yeah.
And then, they were like, oh, she'll grow out of it. It's probably just like, the absent seizures that she could grow out of.
Yep.
But she didn't.
Yep.
She now has complex partial.
Yep.
And now she's on her flu.
That makes sense. Yeah.
And she's still waking up.
Yep.
All night, and they're still not doing anything more than just giving her the medication during sleep testing or.
Yeah, I mean, if you haven't done EG recently, you do it to see, if there's still discharges at night, because that is a common reason kids wake up, and maybe she needs more Lamictal, or maybe a second med, or maybe a switch in meds, but I do run this a lot where I used to, I'm a family doc, and family docs, there's family docs that deliver babies, do C-sections, do all kinds of, we're kind of used to doing jack of all trades, right? So I used to get these patients with these abnormal EGs, discharges, and send them to a neurologist to get treatment, and they'd come back and say, the neurologist said we don't need to treat it. I'm like, what's going on here, So then I'm like, well, I'll treat it. So I started treating patients and taking it seriously and doing EEGs and making sure that it's getting better. So what we would do is you got discharges, you treat it, EEG, keep treating until you get the discharges to go away or at least get them a lot better. And then you might see better brain function, better sleep, all these things too. Now maybe she's got other sleep problems, like some kids have sleep apnea or they have GI issues that make them wake up because they get reflux heartburn and stuff like that. A lot of kids that have sleep wakings will do a sleep study too to make sure they don't have sleep apnea. So you might look at other things too, make sure you're not missing something else, like a sleep apnea or something. But at least in typical kids, they're a little different. Sometimes they outgrow their seizures. In kids with autism, they don't tend to outgrow their seizures. In fact, I get a lot of these kids that see a neurologist, you've been seizure-free for 2 years, you can stop the med. And most of the time when they do that, the seizures come back or the EG gets worse again. So I always caution patients, let's not stop the med, let's keep it through puberty. Now I've been keeping it even in the 20s because I have some kids in their 20s getting seizures too. So I can't say 100%, but a lot of kids with autism, if you stop their meds, after they're better, the seizures come back. You don't see that in typical kids. It's more kind of autism because they have a lot of these other underlying neurotransmitter abnormalities that predispose you to seizures and so forth. Yeah. So yeah, another EG, maybe see someone who can treat the discharges better and rule out other problems too, Yeah. 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 The question is about low-dose naltrexone. Naltrexone is a medication that blocks opiates in the brain. So there's 25 plus studies using autism, and they do high dose. They do this kind of 2 milligram per kilogram dose or higher, and it can dramatically lower self-injurious aggressive behaviors, temper tantrums, irritability, sits a chill pill, and it works within a few days. So we do a lot high dose. The low dose and the high dose have an anti-inflammatory effect. What I find with LDN is the effect is kind of modest. You know, it's kind of mild. It is anti-inflammatory. It's enough to treat seizures or make a difference. Probably not in most kids, but it's pretty benign. It has almost no side effects except for drowsiness, but not the low dose. I mean, and it has no drug interactions. So it's really easy to add, and some kids respond to it, but it's kind of a mild effect. Yeah. Yeah, it's immune modulator, so it's kind of supposed to kind of turn off some of the inflammatory response, kind of have an anti-autoimmune response. So it sounds like your child may have at least a component of autoimmune, something going on that's causing the seizures. So, and some kids, can be tricky, and so you have to work with a doctor who understands this, is you could have a mitochondrial problem, autoimmune issues, and CFD, and who knows what else. And if you have 3 problems, you treat 2, you might be okay. You treat 1, maybe not so much improvement. Treat 3, you get better improvement, right? So sometimes you have to think outside the box and look at all these things, right? And most doctors can't do that. They're looking for the problem. What's your kid's one problem? Like, well, your kid might have 5 problems, and you have to treat all of them. We also find that some kids with autism have bad bacteria in the gut, like Clostridia, that creates chemicals that can make them seize more. So we get that sometimes too. So you have to look at the whole picture. You have to look at the gut and the brain and all the metabolic issues and so forth. And you have to be very systematic. So that's how my brain works. It's kind of, so in order to not miss stuff, you have to really be, okay, let's run all the tests, make sure we find all the problems, and yeah, so it's almost like having, those crime scene things where they put all these things on. You have to kind of be like that. You're like, you make sure you cover all your bases, like at least check things once so you don't miss something, right? So, other questions? I don't know if we're out of time or is the time up? Yeah. Yeah, go ahead.
On the longer EEGs.
Yeah.
Ambulatory or in a hospital?
That's a good question. A lot of the ambulatory EEGs have video monitors where you can put on the kid. I mean, the advantage of being in the hospital is lead falls off, you put it back on. You can really zero on the kid. The disadvantage is you're not in the home environment. And some kids will get seizures because of what's ever going on at home, like a sound or something weird goes on. So I like the home ones because you're kind of in your environment. You can sleep a little better at home than in the hospital. Because a lot of times you got to get good sleep or decent sleep to get a good EEG. If you're in the hospital, they come in every 2 hours, waking you up and stuff, you may not get a great read. So you could argue for either one. I know a lot of doctors like to do it in the hospital because you can watch the kid. But a lot of the kids that we see with autism, if you look at the video when they're having the seizure, you don't necessarily see anything because it might be affecting speech or attention. So a lot of times you look at video and nothing's going on. There's no clinical manifestation, but it could be it's impairing speech and the kid's asleep and not moving, but they might be affecting speech and stuff. So I don't find the video portion is that helpful. We're looking at the raw data. Is there an abnormality or not? Because a lot of doctors, what happens, they'll see the discharges and be like, well, nothing happened on the video, so clearly it's not causing a problem. Look, how do you know it's not causing attention problems or speech problems or cognition problems or whatever? So the video part to me is not as important as what is the raw data, what is the data showing? And you can do that either way. You just want to make sure you have decent equipment too. Yeah. I think we're out of time. Hope that was helpful. Yeah. Oh, you're welcome.